We would like to thank the American College of Surgeons for the opportunity to present our work today. I'm Anna Velez, and I will be presenting the study titled Measures to Improve Utilization of Multiple Arterial Grafts for Isolated Coronary Artery Bypass Grafting. We have nothing to disclose. In the last couple of years, a lot of research has been done to determine the long-term benefits of using more than one arterial graft or CABG versus a single artery. The use of LEMA is a Class 1 recommendation and a quality measure. We know that saphenous vein patency decreases over time, and the rate of decrease varies among studies, but it is estimated to decrease by a quarter after the first year and by almost half after 10 years. The use of a second IMA is a recommendation in both American and European guidelines, and the use of radial artery is recommended over the saphenous vein. Despite this, the national use of BEMA for CABG was only 5.7% and 6% for radial artery in 2018. Several studies have found that the use of multiple arterial grafts provide better outcomes than a single one. Rocha and colleagues found that at 1, 5, and 8 years, the incidence of MACE and death were lower in patients who received more than one arterial graft, demonstrating the benefits of having a second arterial conduit for CABG. We hypothesized that several measures that took place at our institution, collectively giving rise to the start of a programmatic focus, increased the use of multiple arterial grafts on patients undergoing isolated CABG. We hypothesized that these led to a reduction in 30-day mortality with no impact in takeback for bleeding or sternal wound infection rates. Our cohort consisted in adult patients less than 70 years of age undergoing isolated CABG from January 2012 to December 2019. We used our institution's STS database, and we excluded according to age and history of previous CABG. Our primary outcomes were the number of arterial grafts, single versus multiple, and for those that had multiple arterial grafts, the type of arteries they received, whether it was BEMA, LEMA plus radial, or triple arteries. Our secondary outcomes were 30-day mortality, takeback for bleeding, and sternal wound infection. And we analyzed the incidence of these complications according to time period, before versus after the start of a programmatic focus, but also according to multiple versus single arterial graft use. Finally, we divided our cohort according to date of surgery in two groups. The first one from January 2012 to June 30, 2016, and the second one after a programmatic focus started at our institution from July 1st, 2016 to December 2019. For our analysis, we performed chi-squared, Fisher's exact tests, and logistic regressions. The programmatic focus started with the arrival of surgeon champions at our institution in July 2016. At the same time, evidence-based publications on improved survival on dual arterial grafts started to emerge. That led to the creation of a protocol adopting radial artery as a conduit and retraining the surgical staff in radial artery harvesting. The quality metric also changed around that time to include the protocol, and if surgeons didn't use a second arterial graft in every case, they had to report the reason not to in the following checklist, which would be later reviewed at the monthly meeting. After the initiation of our programmatic focus, specifically after the arrival of surgeon champions in July 2016, there was an increase in the use of multiple arterial grafts at our institution, as shown by the red arrow. This increase went up to 47% in 2017. This percentage went down afterwards due to a change in referral pattern, with more high-risk patients being operated at our institution who had less ideal targets to bypass and a greater percentage of emergent and urgent cases. Despite these decrease, the use of multiple arterial grafts maintained well above the estimated national average, which is shown by the dotted line, and has remained higher than before the start of the initiative in 2015. Here we can see the trends of the type of graft used on average before and after the initiative started. The most striking increase was for the radial artery, which went from being used almost never to 60% of all our CABG. This is consistent with the main focus of the initiative, to increase the number of arterial grafts used by using the radial artery as a conduit. Also, the use of BEMA increased by 4%, and the triple artery increased from 0 to 3%. Secondary outcomes demonstrate that there was no difference when comparing time periods, and we hypothesized that this may be due to the rarity of these complications and difference in changes in patients' characteristics. When comparing multiple versus single arterial graft use, there was a statistically significant decrease in 30-day mortality with the use of multiple arterial grafts, which is consistent with previous studies. And although not significant, we also saw a decrease in the incidence of sternal wound infection and take back for bleeding when comparing multiple versus single. This study has several limitations, such as its observational nature, the use of a single institution data set, the rarity of the complications, and the change in patients' characteristics over time. With this, we can conclude that a programmatic focus has the potential to increase the use of multiple arterial grafts in eligible CABG patients. The use of radial artery can be significantly increased with appropriate quality metrics, and consistent with other studies, the use of multiple arterial grafts was associated with a decrease in 30-day mortality and may become a quality measure in the future. Thank you.